Neither the El Paso County Medical Society, its members, nor KCUS-TV shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
It's October, and we are in a sea/desert of pink everywhere. I'm even wearing it, but you guys aren't. So what's up with that?
Pink accessories.
All right, you have a pink accessory. So it's Breast Cancer Awareness Month, and the good news is this. There's a lot to be thankful for. There is new research, there are new treatments, and tonight we are specifically talking about new technology in screenings. You've heard a lot about digital mammograms, and really in the last couple of years you've heard a little bit about 3D mammograms, and the show is entitled Why You Should Demand a 3D Mammogram. So we're going to talk quite a bit about that this evening. We have a physician, and we also have a breast care navigator, which is huge because she knows everything. We think the doctors know stuff. Just a little. As you know, this is a live program, so if you want to call us this evening, the telephone number is 881-0013. I want to thank very much the Hospitals of Providence for underwriting the show, and again, the people that you're going to be talking to when you call in your questions. The Texas Tech Paul L. Foster School of Medicine provides 2 beautiful medical students, and even if you were a guy, I'd say you're beautiful. But with us today, we have Erin Pines, who is a medical student in her 2nd year. You may recognize her. She's here quite often. And then we have Habiba Khan, who is in her 1st year, and Habiba gave me this really beautiful pencil to write with. So these are the 2 medical students that will be answering the phones and giving your questions to us here this evening. And please know that the El Paso County Medical Society has been sponsoring the show for over 21 years. And the reason I say this, probably been 22 years, but I started hosting this when my daughter was just born. She was 3 months old, and she's about to turn 22. So that's how I know how long the show's been going on. So thank you so much to the El Paso County Medical Society, all of the physicians, everyone here on the air are volunteers this evening, and that matters. So we're trying to bring information to you. I'm Catherine Berg, and you are watching the El Paso Physician. Screenings, it's something that you hear about every year, and every year you hear a little bit something different. So there is the American Cancer Society recommendation, there's a National Cancer Institute recommendations, there's WebMD. There are all kinds of questions out there. We're going to talk a lot about what's new on the horizon in the world of screenings, which really means early prevention. If you can find your cancer, no matter what cancer it is, specifically breast cancer this evening, but if you can find your cancer early and start treatment, your chances for survival are huge, especially in the world of breast cancer with everything that's going on now. So we have Dr. Byron Christie, who is the radiologist. So he's going to be able to talk to us about what he sees when he does mammograms, what he sees when he's looking at the pictures, what he's looking for, because I'm always curious about that. You go in, you know, I'm 51, so I've been doing mammograms for 11 years, and I'm like, what exactly are you looking for? And I've had some issues that are different than other issues, so we'll talk about that this evening. So thank you for being here. And then we have Charlie Swokes, who's been here a couple of times, and I've known Charlie for several years, and she is a breast cancer navigator, and I feel like she is, gosh, you are a trooper, you're an advocate, you're a friend, you're the person that everybody looks to like, okay, somebody's got breast cancer, let's call Charlie and figure out how this all works. So thank you for being here. Dr. Christie, being a radiologist.
Yes, ma'am.
To the people at home, what does that mean? So what do you do all day, every day? A radiologist, and there's a radiation oncologist. There's a lot of names in that field that sound the same, but what do you do all day?
So radiology has really become a very broad field, and the people that interpret the mammograms are diagnostic radiologists, and that's different than the radiation oncologists, who are people that treat cancer with radiation. So we are the people that, in general, you hope you don't get to see, because if you don't get to see us, your mammogram was normal.
Nice.
Most mammograms, even when you get called back, are still ending up as normal, but then you get to see us. And you get to come in and you get to get more mammography or an ultrasound or some other test, an MRI, and then generally talk to one of us about the findings. And we're basically the guys looking at the images, the pictures on the screen. They used to be on films now, and we used to have these bright boxes that we put things on, and now it's on a screen, and it's projected on a computer, and we can magnify it, and change the way that the image is windowed and really get down and dirty with the images now.
I so specifically want to talk about that because, again, through the years, again, I say I'm 51. I say that a lot just for reference because there are a lot of people that are watching this evening that are in their 40s and their 50s and their 60s. So I give the stories of just when I've been doing all this. And again, when digital mammogram came around, I was like, oh, I'm going to get a digital mammogram because it sounds so fancy, you know, and everything's kept on records. And now we're talking 3D, so that's going to be exciting. Charlie, I don't know how to explain to people what all you do. So if you're in an elevator or in a restaurant and you're waiting to pay and somebody says, hey, I know you, what do you do for a living? What do you say?
Well, I try to explain to them that we navigate patients through their breast cancer journey. We actually start before someone even has breast cancer. If someone has abnormal imaging, abnormal mammograms, we have 2 navigators at the hospitals of Providence that get involved right away. So we try to help them with any barriers or any education support, psychosocial support, anything they might need throughout the whole journey. Some people, you know, as the doctor mentioned, everything's normal and they go on their way and they come back for another screening later. But those who are diagnosed, then I really jump in and I try to help them through their surgery, whatever treatment they may have, chemotherapy, radiation, support groups. So it's really the entire spectrum of someone's breast health issues.
And I like how you said it starts even before there's a diagnosis. So when, and I'm going to go back to just myself because that's the person I know. When I was 38, I just felt something a little bit funny, and I thought, you know, I know I'm not quite 40, but they said if you feel something, and again, I'm like medical advocate lady, so I feel like if I didn't go do that, I'm in trouble. I'm doing the show. If I don't go do that, I'm in trouble. And so I had a mammogram, which was normal the first time. The second time I went, I had microcalcifications. It's not something anybody really talks. It's so rare, and rare even more that turns into some kind of a cancer. So being 38, you think about, okay, well, there's dense breast tissue still. So is that a sonogram type thing? You can't find microcalcifications on a sonogram. You can only find that on a mammogram. But I'd like to talk about when, and this is a loaded question, when do people start screening? When was the acceptable age? And then it kind of changed, and now it's changing again. And it's a loaded question. I'd love for both of you to weigh in on that. But again, I had some, I don't know, I'm going to find out. 38's kind of young. But what would you say to people watching the show?
So the American College of Radiology is the governing body that really, to us, matters the most as far as the recommendations to women, because that is, we have to follow those recommendations for our certifications. And it's well established that 40 years old is when we should start screening. We used to say between the ages of 38 and 40 is when you should get your first mammogram.
Okay.
And this is all else being equal. So 40 years old, you start getting mammograms, and every year thereafter.
Okay.
And if you mentioned earlier, if you can't remember, if you're having a hard time remembering it, do it on your birthday. Give yourself a present.
Exactly.
Get your mammogram. So.
And if not, at least make the appointment on your birthday.
Right.
That's right. Now we're starting to risk stratify people. If we have a patient that is a known high risk patient because of their family history of having breast cancer, especially on the maternal side, then we will look at that and find out when their relative was diagnosed. And especially if it was an early diagnosis, like in the early 40s, often we'll turn the clock back about 10 years on those ladies and start screening them. If it was 42-year-old when their sister got diagnosed, then we'll start at age 32 on them quite often and do genetic screening.
Exactly, and that's what I was going to say. I said because we can do an entire 8 hours on genetic screening.
Right.
I want to touch a base on it, but I don't want to go crazy on it.
Right.
And Charlie, I'm going to ask you because it is the question on everybody's mind. So we talk about screening starting at 38 if an insurance company will take care of it. And this is also loaded. It's never a fun question, but it is a necessary question. When and how, when meaning at what age, and how do insurance companies usually handle the screening process? And you may have, and you may not. And if you don't, we just don't. The question we were talking about before the show started is that we talk about regular mammograms, which now is a digital mammogram for the most part, because about 10 years ago, you said about a decade ago is when digital mammograms kind of became the norm. So prior to that, it was all on film. And I still have film mammograms of my microcalcifications. So regular mammogram and then 3D mammograms. I know that you said you know the cost difference at your place, but in general, could you explain to the audience some of the costs, how insurance deals with that? Again, as the breast cancer navigator, I'd imagine, maybe think of some of the questions they ask you and throw those out there.
Well, insurance companies will cover a screening mammogram,
okay,
a preventative screening mammogram annually. And they're covering 3Ds. When we first got it, they weren't covering the 3D mammogram.
Okay.
So we were kind of covering the cost on our own, charging the patients for 2Ds. But now insurance companies are covering those as well.
And that's pretty much the norm now?
It is.
Okay.
It is the norm. Pretty much. I mean, we can't speak for every insurance company because...
Right.
But it is pretty much the norm. So annually, they're covered preventative. I get a lot of calls from women who have lost their job. All of a sudden, they have no insurance. There are foundations out there to help. You know, and you can reach out to the Hospitals of Providence Cancer Navigation Program, and we can get you to those foundations. There's, you know, the Rio Grande Cancer Foundation, American Cancer Society locally here that can help get people to those foundations. We offer special cash pricing in the month of October because we just want to bring awareness, get people out, anybody who needs it. And so those are going to be people who don't have insurance that need to pay cash for their screening mammogram. We're talking about screening again. And for a 2D mammogram, our cash price is $60. And
really?
That's with the radiologist reading and everything.
Very nice. Okay, so that's $60 for 2D mammogram and the reading from the
Correct.
Radiologist. That's all inclusive.
Yes.
That's a beautiful price.
It is. And the 3D goes up to $130.
Okay.
Again, if someone needs assistance, we will figure things out. We don't want people to go without screening. So that's our job. I mean, that's one of our main priorities is getting people screened.
I should have asked you this before we went on the air. Might you have a phone number you can throw out there?
I can.
Excellent. Go for it. Yes.
So I can give my main number, which is to the navigation department. It's 915-577-7186.
7186. It's always nice to give that out when people are watching the show. Again, 577-7186. And again, 915 is the area code. We'll give that out again before the end of the evening. So again, it's so very important for screening. And I'd like to go back to Dr. Christie, and let's talk a little bit about genetics. And because we're talking about testing for this and testing for that, and what are your chances here and what are your chances there? And now I feel like it's an old story, but like 5 years ago, we talked about Angelina Jolie and all the testing she did, and she had everything removed, and we thought, is that crazy? Is it not? You know, it's been all over the map when it comes to this. So I'm just going to let you handle that question how you will.
We're getting better, and I'm no geneticist, but we're getting better at understanding this. And, you know, I would like to make the point that most women that get diagnosed with breast cancer have no genetic predisposition and do not have a relative with breast cancer. But if you are at high risk because of a genetic reason, you know, you must be extraordinarily vigilant. And I mean, it's even more important. It's important for everybody, but if you're known to have that issue, then we need to explore it. And it's really easy to get genetic counseling where they do your DNA just like they do, you see on TV every day, you know, me and my 23 or whatever.
Right.
Didn't mean to give them a free plug.
No, 23andMe. No, I get it. And there's Ancestry.com. There's a whole bunch of them. So that no, we all get it. No, it's
but it's very important to make both points. Most women that get breast cancer do not have a family history or a known genetic predisposition. And just because you have a high family history, a bad family history of breast cancer, doesn't mean you're going to get it. But it means that we really need to be vigilant, and we're starting to risk stratify these people more and more, and have more intense screening to include MRI sometimes.
And I like that you talked about, and I love very much that you brought up the point that it's not necessarily that you're at a higher risk just because you're out there. The genetic screening, and I want to really not scare people, and that's why I want to bring this up. If you have been diagnosed with breast cancer, that's kind of when the genetic screening or the genetic testing comes into place, because now you can see if maybe you have a gene, maybe your daughter will have the gene, or maybe your next niece will have the gene.
Yep.
And so when we do have these genetic shows that are specific on genetic testing, that is such a clear point that our doctors make, that it is more about helping the generation right underneath you. If you have breast cancer, find out if you have that gene. If you have breast cancer, again, it's also in a way of treatment to try to figure out how to treat that. And I don't know if either one of you want to talk. So I know that we're not here for treatment at all. And I want to make sure that we know that this is really about screening. But sometimes it's nice to know, because you hear, like right now, I can think of 3 women that I talked with this morning, because we had a news conference about breast cancer this morning, that have 3 very different types of breast cancer. So all 3 of these women are getting very different types of treatments. And so, Charlie, I'm just going to throw this to you. And again, we're not specialists on treatment this evening at all. But how can that be, and how is that navigated on what type of treatment you get?
Well, as we spoke earlier, with technology advancing, we've figured out the biological makeup of these tumor cells. And so with all the research that has been done in the years, we've been able to figure out this woman's breast cancer as opposed to the woman next to her breast cancer to the molecular level.
Right.
And so with that and research with medications, we've been able to target specific breast cancers in different ways, different types of chemotherapy. Some are IV, some are pills you take. It's very specific now, very specific. And it's not treated the way it used to be, where everyone got the same chemotherapy at all.
And that's something, too, that we talked about in the beginning of the show, that when you have a type of breast cancer and the screenings, I want to talk a little bit about what it is. And Dr. Christie, if you can describe to us, and because you're old just like me, talk about prior to digital and what we were looking at when literally you put the X-ray on the light.
So it's you've had a piece of film. It's literally a radiograph that is like a photograph. You've put a 3-dimensional object and put it onto a flat piece of film. And so you've projected all of those various structures that are contained within that round thing onto a flat piece of film. And we took, as everybody knows, we take 2 views. We take, one like this and one like this. And we're trying to, in our brains, in the radiologist's brain, put a 3-dimensional shape to these objects we're seeing in 2 dimension.
Right.
And so then we came with a digital mammogram, which improved our ability to see through dense breast tissue and allowed for a wider latitude of exposure, so we had less problems with areas of the image being uninterpretable. But we're still on a flat screen. With the 3D mammogram, the tube rotates as it takes the image, and it basically takes slices, almost as how a cartoon is a series of drawings that each one is just a little bit different. And viewing a 3D mammogram is the same. We're looking at one sheet at a time. And so if there's 2 structures that are separated in space, we will not add them together like we used to on a flat piece of film. We will see just this one all by itself, and then as we get farther into the image, then we'll see this one, and we will not confuse them. So it's much more accurate.
And I love, and Charlie, I'm going to ask you, and this is not sexist, but you're a girl, so being in the room, because 50% of the people that are watching have had a well, let's hope that 50% of the people watching have had a mammogram, but you're in the room, and this year was the first year I had a 3D mammogram, so prior to that. So it was interesting, just the different, not really the different positions, but how the camera was working or how the machine was working. And I'd love for you, as a woman being in there, describing, I would love to do this actually. Let's pretend that no one has had a mammogram yet. Let's describe what it is to get a mammogram. And now what it is to get a 3D mammogram. And it's not that it's a huge difference in there.
It really is not a huge difference.
But just describe what happens when you go into the room.
The time difference is with seconds.
Yeah.
So you go in, they ask you to wear a robe, leave your deodorant off, lotions off, and they put
take
you
off your diamond necklace.
Yes.
That's very important.
They put you up to a machine and they compress your breasts. And it's pressure. From experience, it's pressure. It's not really pain. And with the 3D, it takes it in an arc, and I think it's probably 8 to 12 seconds longer. It's not much longer. And so they take the views, and then they compress it, and you're done.
And the nice thing too is they're in the room, the technician can usually say, you know what, I've got a good image, or you know what, I didn't have a great image, let's do it again. So that's the beautiful thing too. There's a lot of accurate and right then and there time that's being said. I do want to announce to the audience our computer graphics are down. So if you do have a question, again, this is a live program. If you have a question, give us a call at 881-0013. We have 2 medical students from Texas Tech that are going to be taking your calls and then giving them to us. Again, the number 881-0013. This program is live. You get to ask your questions. And also we are running live on Facebook. So if you go to Facebook and then look for El Paso Physician, we should pop up. And if you go to Facebook and look for KCOS TV, we should pop up. So that's live, and you can also go back and watch that later. So again, 881-0013 for live questions from the audience. So you just answered a question, Charlie, about the 3D mammogram, if it takes any longer. Really, if we're taking it seconds,
it doesn't.
That's like picking up some water, drinking it.
It really doesn't take much longer.
Oh my gosh, somebody put wine in these glasses. Have you tried some? Just kidding. So let's talk about, if we could, Dr. Christie, in identifying cancer. So we talked a little bit about different cancers. And again, we've got digital mammogram, which let's just say is the standard now, but 3D mammogram. So there are different tumors that may present differently, and I'm kind of speaking out of my expertise level. But as a person who is looking at these screenings, what type of tumors look different from other tumors?
Well, we find that the different tumors can look different. The cell types can be harder or easier to detect. But they basically look different because we're finding them in different stages. You talked about the microcalcifications. Microcalcifications develop often inside of a duct that is cancerous because of the dead cancer cells that basically end up filling up the duct, and then they get calcified as a part of the process of their dying. And so we're seeing
I've never heard it explained like that before. That's totally me. Jeez Louise.
Yeah,
okay.
but microcalcifications
Sorry.
Microcalcifications don't mean you have cancer.
Right,
it is just
exactly.
a sign. There's some microcalcifications that are clearly benign and others that are clearly malignant. And then there's
So from a 3D mammogram, you can see that without going through a biopsy? Sometimes you can, and not always. But
you can have a really good idea.
Really?
Yeah.
Okay.
They're
that's past. That's
they're
before my
categorized.
time,
They long ago, American College of Radiology categorized findings on mammograms into categories, and they're risk stratified basically. So, a category 1 means it's normal. A category 2 means, hey, there's a calcification that is a typically benign calcification. We know it's benign, but we categorize it in our report. And then category 3 is a probably benign, everybody's least favorite. And the chances of that being something bad are in the range of 1% or less.
Okay.
And then you have category 4, which is suspicious, and they've subcategorized that. But basically, it means there's a 20%-ish chance that it's something bad. And so most of the people that get called back and end up getting a biopsy have a category 4 suspicious. That means that even if they get biopsied, there's a 1 in 5 chance that it's something bad.
Okay.
And then there's a category 5 where it's not 100% certain, but we're pretty darn sure. And it's a 90+% chance.
And let me explain to the audience, because I remember when I got my results back and it said, a possibility, there's microcalcifications, I've never heard that before. So basically, and correct me if I'm wrong, but what you're seeing, again, this is old mammogram, but what you're seeing is you took a salt or pepper shaker.
Little white dot.
Little white dot. So on the mammogram, it's not like a tumor, it's a bunch of white little dots in there, and they look like they're microcalcifications. So I thought, I've never heard that before. So the biopsy is very different too, because the biopsy now is something maybe, the size of a pin here, going in, and they're taking out little, and I think I probably had like 30, 40 of them. So
Right.
they're taking out groups of these microcalcifications. They're sending them off to the lab. They're seeing if they're scary.
Right.
Thankfully, everything was fine. But I'd love to talk about markers, if we could, because again, you're a reader of mammograms. So I have 3, because I've had 2 different biopsies done, 2 different years apart. So I have markers in my breast. And so when I go in, as we were talking about, into the room, and they're like, okay, I see that you've got some markers, and I've got one that's kind of hanging out up here because it got lost as they were trying to put the marker in. So I've got one on my chest wall right by my bones, and they're like, why is that there? But let's talk about that, because people who have had biopsies, there is a mark where that possibility was in the past, so that you reading the film, or reading, not the film, sorry, I call it the film. What do you call it now?
Yeah, we
reading the
still call it
mammogram.
film.
You still call it the film. You reading it, what are you looking for in maybe something that was suspicious, let's say 20 years ago now, but there's nothing there. So how are you reading those mammograms?
Yeah, so we see this little piece of titanium wire generally, and now they put them in, the little mammogram symbol shape, like little pink
do they
ribbon.
really?
Yeah, some of them. And some of them are just a little twisted piece of wire, and
Okay.
others are kind of look like a little plug.
I have
They're
a
all-
twisted piece of wire.
Yeah,
I have
they're
3
all
of those guys.
You're twisted. They have a little piece of metal. It's a little piece of metal
Yeah.
that we can see. It doesn't set off a airport
Thank God.
machine, but it can be easily seen on the mammogram. So the next radiologist, which people move and
Right,
may
exactly.
be seeing
And that's
a
why I
totally
want to bring this
different
up. We have a
person.
huge Fort Bliss contingency here, people in and out all the time.
But we all know what that is. And if there are calcifications right by that marker, and we know that that's been biopsied, and we don't want to call somebody back for something that's already been investigated and proven to be benign. If it ends up that we have taken all of the calcifications out with our little biopsy, and they won't be there to be seen anymore on a mammogram, we still have to be able to find that spot. The surgeon has to be able to find it, and we go find it for them. We can see that little marker on ultrasound quite frequently, and we go in and we ultrasound and put a little teeny wire right beside it, and now the surgeon can follow that wire down and take out a proper amount of tissue as a lumpectomy, make sure that they've got margins and all that cancer is out. And so that's the 2 reasons that you put the marker in.
Okay, beautifully explained. Charlie, I know we talked about this before the show. I don't think we said it when we were on the air, but how long, más y menos, has the 3D mammogram been? Now it's somewhat normal, but how long approximately has it been out and about?
Well, we've had it here at our Imaging Center West on Sunland Park 4 years now.
4 years. Okay. All right. I thought it was less than that.
No.
Okay.
It was about 4 years.
So on average, if someone's going for their first screening mammogram, is it an option really to say that, yes, I would like to have a 3D or a 2D? Is it something that when you walk in, or is it something that your doctor recommends? How in the world of, again, the title of the show is why you should demand a 3D. So on that note, that's my question to you. Since that's the title of the show, why should you demand a 3D mammogram?
Well,
And say it's your first one,
right.
you don't know anything, take it from there.
for number one, we're detecting earlier cancers with the 3D mammography. So the tomosynthesis has really changed the landscape of that. We're finding cancers much, much smaller. We're finding cancers on women with dense breasts that you couldn't see before with your traditional 2D. And myself included, I was one that was always called back for a second look, for an ultrasound. If your appointment is a week or 2 weeks after that, that is not, we don't do that. We try to get people in right away, but you have that anxiety.
Yeah.
So other than just finding cancers, it's a great modality to find them earlier and find them in women who we had to call back to get another look at things. It really is. And yes, you can walk in and ask when you schedule, you can request a 3D.
Okay.
You can ask for a 3D tomosynthesis.
Okay.
It is.
A question here from the audience too. When you, and I think many of us had false positives and also false negatives. So I do want to just bring that up, not spend a bunch of time on it, but as the reader of mammograms in general, what might cause, let's see first, what might cause a false positive?
So a false positive would mean that we've called somebody back because we're worried about something and it turns out to be nothing.
Which is a beautiful thing.
It's a beautiful thing,
Yeah.
except for the stress that that Charlie was talking about. It really is a thing. I mean, people really get rightly stressed out, you know. I mean, I hope that people watching the show would realize that most people that get called back don't have cancer.
Right.
But, you know, you start convincing yourself that you do. So we need to reduce the number of people that we call back and reduce the number of false positives.
I'd much rather
So
get a call back and make sure it's okay.
Dense breasts are a reason for
Right.
you know, false positives, because it's harder for us to interpret, and we're afraid that, you know, we can't tell, and so we need to get you back and smash harder or look with the ultrasound. But with the 3D, like I said, we're able to look at really thin slices and demystify this complicated picture. Mammograms are complicated to read. They're one of the hardest things for the radiologists. I mean, we call it an eye quiz. You know, most radiology isn't an eye quiz. You know, it's pretty cut and dried what's there.
Right.
And a mammogram is a very complicated picture if you've seen it, especially somebody with dense breasts.
Exactly.
And so,
explain, if you can, because I know we can't see it right now. But when you're looking, and you're right, I've seen this too, and they were even showing me mine. And again, microcalcifications, they're glaring.
Right.
But when you're looking at a growth, and sometimes they're cysts.
Yep.
And if you're thinking, okay, might this just be a fluid-filled cyst? Might this be a mass? What is it that you are trying to decipher? And what are you seeing? If you can describe that. I know it's hard.
So, you know, if you have a not dense breast with a cyst in it, it will look like a round ball for the most part. You know, a denser than the surrounding tissue ball. And it will have smooth margins, and it will not have what we call architectural distortion. Architectural distortion means that it looks like it almost looks like there's a little tornado in there. There's a little, you know, the tissue's being distorted. And that's one of the subtle signs of cancer that's hard to pick up. And so we might see, in a dense breast, we might see part of a margin of that cyst and not the whole thing, and we may not be able to tell if it's smooth. With a 3D, its power to separate the tissues from one another, so we're not projecting that cyst over another blob of dense breast tissue, we may well be able to see, that's just a round cyst, and it's very smoothly marginated, it's benign. We do not need to call the patient back. On the other hand, we may see the two-dimensional representation of the mammogram, which we get at the same time as the 3D.
Oh, you do. So it's automatic. You get a 2D and a 3D when you get a 3D. Okay.
Yeah. So
Didn't know that.
So we look at the 2D.
Okay.
Looks normal. You go look at the 3D data set.
Interesting.
Stands right out, and you go boom, and we
Wow.
would have missed that.
Interesting.
And so that's the power of the 3D, and that's why we're here talking about it.
Okay. Nicely said. So, Charlie, let me take it to you for a second, because again, many women have had cysts. And maybe in the older days, it's just something, come in and let's do an aspiration. And let's talk a little bit what that even means. So if you could define what a cyst, a breast cyst is, and say if you haven't had the experience, what would a doctor and or a radiologist do to see what is in that cyst, if it's a tumor, if it's a et cetera?
Well, typically it's fluid filled.
Okay.
And oftentimes they resolve on their own.
Okay.
But you do have to come in occasionally and get what we call an aspiration. That's with the needle, take out the fluid. A lot of times the radiologist can tell they don't have to send anything off to the lab to pathology because they can tell it's a benign fluid.
Okay.
And
how can they tell? I don't know if that's even
Because
something. I'm just curious. I mean, that's just like, how do you know?
They're much smarter than the rest of us. They are much smarter than the rest of us.
And that was my problem. So I felt something when I was 38. So I was talking about that story earlier. I felt a bump, and thankfully it was just a cyst. It was aspirated. It was fluid. It was fine. They did send it in, though, because I remember that, because you were talking about that cuss word period of days when you're like, what's happening? And beautifully it was benign. But the idea of the fluid, because I always think in my head that a tumor is a mass that's solid. And so when I was getting that aspiration back when I was 38, I thought, well, why would they be sending it in? Because it's fluid. But I guess that's just something,
Well,
and Dr. Christie, feel free to...
You can have a tumor with a cystic component. And so when we do a cyst aspiration and we do it under ultrasound, we can see the cyst, put our needle in it, we watch the cyst disappear as we pull the fluid out, and if the cyst completely collapses and there's nothing left, there's no other thing there, there's not a solid component, and the fluid isn't bloody and it looks typically like how it looks all the time, and we see a lot of it, then we're done.
That's it.
Nicely said. Charlie, I would love to ask you, just as the person who is listening to patients and patients' families and the caregivers and everybody who's scared to death, what are some of the most common questions that you get from people, and let's say there has been a diagnosis, because there's also that time frame of there's something funny with your mammogram, let's go back and check it out, but now they're kind of given to you to navigate through life. And I remember several years ago, I had a girlfriend of mine, and because I worked at the Cancer Society for 12 years ago, and she said, okay, I have breast cancer. I really don't know what to do right now. Who do I call to find out what doctor I go to? Who do I call? I've been told by the screening I've got cancer, and then it was like, now what? And so we went to Pat, and I will give a huge shout out to the Rio Grande Cancer Foundation.
Absolutely.
I called up Patty Tescadenu, who I've known for 1,000 years. I said, Patty, I know I've been in this world for many years, but now my girlfriend's asking me, and what do I do? She goes, just bring her over. And you know Patty's voice, just bring her over. And there was Yuta at the time, and they just kind of talked to her, and this is where you go now, and this is where you go now. And it really was navigation.
Right.
It was, what do I do? So if you can take that question in the most, I don't know, case study kind of a way of somebody has cancer, brand new, I don't know what to do. What do you tell them?
Well, and I do get most of questions that they've asked or their physicians have already answered, but because of the overwhelming
Say
amount...
they haven't found a physician yet. They've just been diagnosed. They don't know how to look for a doctor because they went for their screening. They got a positive result. They went back for another screening. Right. It's positive. Now do I do? I mean, it's right at that
at the very beginning.
Exactly.
We can help direct them to physicians, whether it's in their group. We help, find out what their insurance, who's in network for them. We can help direct them to where they need to go and direct them through different organizations, like you said, like the Rio Grande Cancer Foundation. But even things as you would think as simple as finding a doctor, when you've received a cancer diagnosis, everything kind of goes out the window.
Right.
Like I was saying, it's a lot of information in a short amount of time. So that's why we're kind of here to reiterate information they have, help direct them to places they need to go. I also get a lot of questions about, well, my neighbor had cancer and this is the treatment that they're getting, but my doctor's suggesting this treatment. So there's a lot of education that goes on with patients because they don't know that there's so many treatments, there's so many different avenues now for breast cancer, and how successful certain treatments are, and the waves that breast cancer has gone through. So there's a lot of education because they feel like, I know all these people with breast cancer, and why am I getting something different? Why is my surgery not like my neighbor's?
Exactly.
Why? Right.
Yeah, so, and I think that freaks women out until they start understanding, and this is what's beautiful. And I'm going to say 40 years ago. I've been doing the show again 21 years, but even at that time, there were different types of treatment. But I feel like when we first started doing the show, it was like, well, first you go and you get either the lump removed or your breast removed, and then no matter what, you go and have chemotherapy, and then after the chemotherapy you go and you have radiation, and then you just go and you wait for your 5 years of survivorship. And I feel like that was the mantra for so many years. And then somewhere along the way, and whoever wants to take it, and I don't know if it was 15 years ago, I don't know when all that happened, but all of a sudden it's like, oh, wait a minute. You're doing chemo first to shrink it, and then they're going to take the tumor out, and then, so I would love for you just to kind of walk through when and how all of this started changing, meaning we were talking about the intro of the show, there's new research, there's new treatments, there are very specified radiations now. Again, it's such a beautiful thing that I just like to brag about all of this pink. I mean, I know people get tired. I'm tired of pink already, but this is what I live. I mean, this is something that we do. But it has really done well. And I know that there's going to be this huge movement in El Paso next month for male, and I'll look at you because you're the guy at the table, but for male cancer awareness, because I just feel like the women have taken over and it's all about pink. But it has made a huge difference in treatment over the last, I'd say, 18 years. Can you kind of talk about that
Sure.
road?
But on that note too, we're talking about how pink and it's women. We have to remember the males.
Yes, exactly.
Not very many. Under
And so
1%.
blue next month, it's all going to be about blue. There's going to be a big campaign, so you need to start wearing
But
blue
I'm
ties.
talking in the realm of breast cancer.
Yeah.
Oh, you know what?
We don't talk enough
Thank you,
about male
Charlie.
breast cancer.
That's true. We don't talk about
don't.
that.
It's
And
not
we've got like
frequent.
2 or 3 a year in El Paso.
No, well, myself, I probably have a couple a year.
Okay.
In this year, I had 3 in 1 month, which is
Oh, my Lord.
alarming.
3 male breast cancers in 1 month.
Yes, and so it's a small percentage, 1% or under, but males need to be aware of it. They need
Right.
to know their family history. They need to know what their mother. They need to know their body. So we don't talk about male breast cancer enough.
That's true.
We just need to make men aware that it's
It
possible.
can happen.
It can happen.
Yeah.
And
It's
we do
rare, but it can
mammograms on
happen.
them.
So how would, and so here's the crazy question. You know, if you're a woman, you get screened at 40.
Yeah.
You're a guy, what are you looking for? Are there signs and symptoms? There's, like you said,
Palpable abnormality.
okay. And when you say palpable, what does that mean to the normal
You can
second
feel it.
grader?
You can feel
You can
something.
feel it, exactly. So you can feel it, something just feels a little bit funny, or
Right.
there's a dent. And I think sometimes we don't talk about the dents. Mine was a dent. It's like,
Yeah.
you know, I braid my hair all the time. So I was braiding my hair and I was naked, braiding my hair. But that's how you find stuff, right?
That's right.
And I'm thinking, you know, there's a dent right there that shouldn't be there. And that's why I went in. So with men, it's the same thing. You
Yep.
find something that just looks a little bit off.
Yep.
And at that point, don't be shy to ask your doctor, hey, check this out. Do I need to go? You know, because if you're a guy, you're not going to ask. So as a man, and we're at 15 minutes, as a man right now, do your thing to all the guys out there and tell them, what are they looking for?
You know, if you feel something in your breast and you're a man, what would be wrong with coming in and having some pretty girl put you in the mammogram machine? You
Look
know,
at you. You're good.
Look,
Get 'em
you're
in
running
the
around
shower.
with your shirt off all the time anyway.
Right. You're good.
Come in and let us take a
You're
look.
good. And again, just for everybody, and Charlie, I'll throw this to you. Again, years ago, it was BSE. It was breast self-examination. It was mammograms. And then for many years, breast self-examination wasn't a thing. And now it's kind of sort of becoming a thing again. And I'm talking about, when I say a thing, that the different cancer organizations nationally were
Right.
kind of like,
Guidelines.
well, you can't really find things. Talk a little bit about that, because that's the only way a man would be able
Right.
to find something.
So we still believe one of the most important things is knowing your body.
Bingo.
Knowing your body. So whether you do your self-breast exams, you know, do them the same time of the month. For women, especially in the shower. You know, males, when they're showering, just know if something's different. We've spoken about this early. Most masses are not going to be cancerous.
Right.
But you never want to let something like that go unchecked. You need to seek professional help. Go see your physician, clinic, whatever you need to do. If something is different in your breast, you need to bring it to someone's attention. And that's the most important thing, is knowing if something's different. Something is there that wasn't there last month, or something got bigger. You know, you really need to bring it to someone's attention. And that's the most important thing.
Agreed. And I'm going to say that even though we're talking about breast cancer tonight, it's with anything in your
Absolutely.
body. You know, anything feels a little bit odd, if you're breathing funny, if your foot's turning purple, I mean, all that stuff. It's just, I know we talk about prevention on the show, and I know you're tired of it, but it matters. So
It
if there's
does.
anything a little bit off and you're just not feeling right, just go to the doctor. It's what is there to lose? There's, and I know people think, well, it costs money. I get that, but you know, your life is a little bit more important. Dr. Christie, I want to talk to you a little bit about, because I know we're at like the 13-minute mark. So you know what I'm going to do? I'm going to wait on this, because we want to talk very much about 3D mammo. So is there something that we have not yet covered tonight that you'd like to get across the audience, or something that we even talked a little bit about that you'd say, you know what, I'd like to expand a little bit more on this? Because what happens is all of a sudden the show's over and there's a lot of stuff that we forgot to say. So
Yeah.
that's what this moment is about.
So, you know, the message is, cancer screening for breast cancer is getting better all the time. There was a big leap when we went from film mammography to digital, and this leap is much bigger than that. And so there is really almost no downside, maybe lasts a few seconds longer, that you're in compression, but you are so much less likely to get called back. And I think we may have touched on that a little bit, but that's a big deal. So we are probably twice as likely to call you back with the old way that we did it than we are with the new way. And you know, from a hassle standpoint, from an emotional standpoint, that's a big deal. And at the same time, we're finding smaller cancers that we literally cannot see on the 2D that we get at the same time. And so it's a massive leap in technology. I would also like to say, because when you were talking about how much better and how much different things are now, we never used to have people like Charlie. We didn't have the program set up. We didn't have a multidisciplinary team, and we didn't, customize the treatment of every patient. And now, with the pathologists that can do so much more diagnosis on the tumor itself, and we have these meetings. People get their cases discussed prior to their surgery. That's enormous. That's huge.
It is huge.
And Hospitals of Providence have a very, very good program, and a lot of dedicated people discussing those cases every couple of weeks and making sure that we know beforehand the plan on this patient. And it wasn't, like you said, it wasn't just the lumpectomy versus mastectomy, and you got chemo and radiation. It's not the case anymore.
Now, feel free to make fun of me, but back in the old days, I feel like we called that tumor board. Is that still what it is? And that's so, and again, what I loved about that is usually we'll have 3 docs here, and they're all from different disciplines, and everyone is taking a different look at it. And I remember the first time we had a show that talked about that, I was blown away that was even a thing. That your case, whoever you are, sure, you're number 22B, but hold on, this might look a little bit funny. And another doctor looks at it and think, well, wait, you know what? I had something 2 years ago that was similar to that. And I loved that. And I didn't know that was, again, this is, 18 some odd years ago. But I love that still occurs. That is a normal practice. And Charlie, you were going to...
Well, as Dr. Christie mentioned, we have at Imaging Center West, our breast center is a center of excellence. So we have this interdisciplinary meeting, and it used to be the docs, but now we have a navigator, we have occupational therapy there, we have nutrition if needed, we need to get in touch with the nutrition, we have a social worker to provide psychosocial. So now it's become, the tumor boards have become bigger with more disciplines involved, helping the patient in every way, not just your surgery, not just your chemo, but if you need something, if you need assistance out in the community with transportation, we're there to help the patient as a whole.
Right.
And I think that really makes a difference. We have very good relationships, all of us, so sometimes we just pick up a phone call, we pick up the phone and say, can you help with this, can you help with that? So we do discuss everything about their images, their pathology, what surgery plan they might need, but there's a lot more to it now with a greater, everyone for the same goal with the patient. Let's get them through this, let's get them the best treatment with a little bit of everything, a little social work, a little therapy, whatever they might need to get through it.
And what is and I'm thinking specifically about you, what is your typical group like? So say there's the woman with breast cancer. Fine, we got her. So if she has a partner, and then often, because we live in El Paso, Texas, and, the aunt wants to come, and the grandma wants to come, and the daughter wants to come, and somebody's flying in from San Diego. And so in general, when you're talking about options of treatment, and I'd imagine you're mainly that person that is in the room talking about this, how do I say this? So often a patient doesn't navigate for themselves, I find. That it's usually the person that is with them that does that. There's the person that's advocating for them because the patient's kind of blown away with all the information they have. How typically does that happen with you? Like, do you see all kinds? Is it usually like 2 or 3 people in the room?
Well, here, because of our culture, I see it in 2 different ways. I see a big group.
Yes.
I see a big group of family
and
members.
I love that. That's one of the reasons I want to bring that up.
So
yes,
do I.
Exactly.
In the inpatient and the outpatient setting, we have big groups. But also because of our culture, we have the women who take care of all their families first, and they want to handle things later and make sure everybody at home is okay. So oftentimes I have someone by themselves.
Oh, really?
Just because, you know, they're the caretakers of their family, and everyone needs to be home and okay, not worrying about her. So it's kind of a range here, and it's cultural. But that's why we're here, you know, to kind of help those women who are alone and the women who are in groups.
And they don't want to burden anybody.
That's it. That's exactly it. They don't want to burden anyone.
Okay.
You know, their family comes first, and they come. We're trying to change that swing to where they're getting their screenings and where they don't put that kind of stuff off.
Exactly.
Because they're caring for their family, which was
if you're not around, who's going to care for them?
Right.
You know, that's kind of the selfish
and
way
we're
of looking
chipping
at
away
it.
at that. I think we're doing a good job in our community.
Very nice. There's a question here from the audience, and I love the way you explained this earlier. If a patient does experience pain during a mammogram, is that normal? And so there is, and again, I just want to be very realistic and very true and honest. Absolutely. Because we do this with colonoscopies too. It's like, okay, really, what do I expect? Because people are freaked out about this stuff. We talk about digital rectal exams. What does that mean? What's happening? So there is compression. And again, if you'd like to talk about that again, because somebody did call, and I want to honor this, that what is the pain? Well, there is a compression. So
and
let's
people
talk about
have
that.
a spectrum of how they feel pain and what they feel pain is. But the majority of patients I see, mainly it's the anxiety, thinking that it's going to be really painful.
Right.
There's patients that it does cause them some pain, and they may have to take some analgesics later, some anti-inflammatories, but I think mostly it's the anxiety, and especially after women have their first one, and then they, you know, and again, I don't want to minimize it at all and say, oh, no one's ever going to feel pain, because that's not the case.
I have a weird personal question to ask here. So sometimes I'll get my mammogram, and there's this beautiful, warm, cushiony pad on the machine, and then sometimes there isn't one. Why? Dr. Christie, as the reader of the films, so to speak, what is it? Is there any...
I don't know if you've noticed, but it's always just women in there doing that. And we're not allowed in there.
Because sometimes, like, where's the pad I had last year? You know.
I do know that some facilities have the pad. And
is it any
I don't
different
know why
to
it would
read
be
from a pad or not? Does that? And I guess that's where my question comes in. Is there any kind of a blockage or any kind of a?
As long as you get good compression, you know, and good compression is very important. And you know, want people to understand that the tech isn't being mean.
Right.
They're trying to get an adequate image.
Right.
And you know, hopefully they're not trying. Hopefully they're not a sadist. But
no, it's just one of those small things. Again, just because you've been in there, it's like, oh, I remember the first time I had a pad, and I was like, this is like, this is Cadillac service, man.
Well,
this is like going to Ritz-Carlton of mammograms. This is fantastic. No, I just didn't know if there was a difference with different machines. On that note, I would like to talk about, and just quickly, just as curiosity, the 3D physical machine, is that different? Like, for example, do different clinics, hospitals have to buy a different machine for the 3D mammography? Let's talk a little bit about that, of why, and again, because you all offer it, who may not, if it's something that's in a rural area versus an urban area, and maybe just go off on that just a little bit as they're becoming more common.
The technology's been around for a while, but as everything else, you know, money drives a lot, and whether or not Medicare or the other payers will pay for it, you know, if no one will pay for it and no one will then come get it, you know, the hospital or the imaging facility, you know, is reticent to put it in. So about 3 to 5 years ago, Medicare started saying that they would pay for it.
Nice.
Because the data showed that it was better. And it took a long while. At first, you know, there was all of this stuff that's just not better, but it is better. And so now they're paying for it, as are the third parties. And it's an investment that the hospital and the clinics have to make, and that the referring physicians and the patients have to begin to accept. And that, that's a process. It was the same process when we went from film to digital.
Right.
People at first said it's not better. There's no data. Well, now then there was data, so then they paid for it, and it's the same thing now with the 3D. And we know it's better. There's nobody that shouldn't get a 3D mammogram. Particularly people with dense breasts, it's for sure better in that circumstance, but it's better in every circumstance.
Right.
It takes us longer to read them, actually, a little bit longer for the technologists to do it, and a little bit longer for you to have it done, like you said, 8 seconds or something. I would say it's close to twice as long to read. There's more images, but we call less people back, and we're much more comfortable that we're finding the abnormality.
I was going to say, I bet you sleep better at night because you know you're reading it a little bit better, and that's beautifully said. And again, I thought it was so important, I'd love for you to repeat it, that Medicare is picking this up, and it's relatively new, like the last 2.5 years or so.
Right.
And that's so important because Medicare, it's like when they jump on board, as you said earlier, when Medicare jumps on board or CMS, then other people start jumping on board, and that's a beautiful thing. So we have about 1.5 minutes left, so I do want to, because there is a beautiful fundraiser, and I don't usually do this on the show at all, but there is a clinic on Peyton Street for the people of Sparks way out on the east side who do not have access often to any kind of medical care. And so this clinic is run by the Texas Tech medical students. There is a doctor out there, but it's a free clinic. Anybody that goes there can get seen for free. And so this fundraiser is specifically going to breast cancer screenings and some of the lab work that is associated with that, which often, again, there's a cost to it, but it is nice if we're able to offer that to the community for free or at a very reduced cost. But the fundraiser for that is on October 28th. It is a 5K fun run, and the beautiful thing is Aaron Pines is over there. I feel like you should look at Aaron while I'm talking about this, because Aaron literally is here like over my shoulder writing it down on a piece of paper. But Aaron and her group of friends and all the medical students are putting this together, and I cannot thank them enough for helping so many people in our community that do not have the money to be able to go see doctors. Again, it's on the 28th of October on Scenic Drive. You will meet at Newman Park, and it's $20 whole to be in this. And again, it's a fundraiser. Even if you don't run, go and register and do that. The phone number is 215-4370. Again, 215-4370. And it is Sprint for Sparks. And again, you can watch this show over again. If there's some things that we just said too fast, you can go to kcostv.org and go to watch programs and find the local programs. You can also go to the El Paso County Medical Society website and look for the El Paso physician logo. I want to thank the Hospitals of Providence for underwriting this program. Thanks so much for being here. Wear pink with pride. I know you'll get sick of it, but it's for a good cause. I'm Catherine Berg, and you've been watching the El Paso Physician. Good night.